A very good evening, everyone. Basically, we have covered LASIK a lot, so now my topic comes where LASIK is not done. So the page comes what is left. So I'll be talking on this phakic IOL, this intraocular phakic contact lens or intraocular contact lens. What is IPCL? IPCL is just a lens. It's a thin membrane-like lens which we implant uh, above the lens, intraocular lens behind the iris. So implantable phakic lens you use in LASIKable as well non-LASIKable cases. Covers myopia -1 to 30, -30, hyperopia +1 to +15 diopter. It can cover astigmatism from +1 cylinder to 15 cylinder, 15 diopter cylinder. The versions, it will be IPCL spherical, IPCL toric, or IPCL presbyopic. Indications, it should be the age should be above 18 years. The refraction should be stable for at least 1 year. Myopia, what we want to correct, that's the choice of, it's the counseling of the patient. Independent corneal thickness, then AC depth should be minimum 2.8 millimeter, and rule out other ocular pathologies. Now, this is basically what I'm talking is how to learn, means everybody as my seniors, my colleagues, they all have been doing it. So what I'm talking is just a few things like anterior chamber depth should not be less than 2.5, anterior and posterior synechia has to be ruled out, glaucoma or raised IOP, evidence of nuclear sclerosis or developing cataract, is there any family history of retinal detachment, patient suffering from diabetes mellitus. These are usually the contraindications for IPCL. Step 2, how to measure. What the preoperative measure for IPCL is basically the refraction. The objective and subjective refraction has to be done very well. Anterior chamber depth, that's the corneal. It should be from the corneal endothelium, what I personally feel. If you are taking it by a scan, the pachymetry should be minus, should be subtracted from it. Then K reading, intraocular pressure, and the most important and tricky thing while doing a IPCL is white-to-white measurement. White-to-white measurement, distance using a digital caliper is my choice. There are so many OBSCAN, Pentacam, there are so many machines available, but still I have to check it, and that has to be done in a supine position, apply anesthetic drop. First of all, calibrate the caliper, take the measurement in supine position under the microscope, and mid-limbal has to be considered, mid-limbal line from one end to other end considered as the best measurement. White-to-white measurement using caliper, this just it's available, applied by the company itself. So nothing much to talk about it when you are doing it. Significance of white-to-white, basically ideal size IPCL will provide a vault, and that vault is very important. Vault means the central distance between the anterior surface of crystalline lens and posterior surface of IPCL. It should be within a range of 0.25 to 0.750, 250 to 0.750 millimeter. So ideal size IPCL will provide a vault between anterior surface, and an underside IPCL may increase the risk of anterior subcapsular opacification, and oversized IPCL more than 1 millimeter vault may push the iris forward, close the angles, which lead to raised in intraocular pressures and iris malfunction. Design advantage of IPCL. There are holes are formed in the haptic structure such that when the mark is on the upper left corner of the haptic structure, the anterior side of the lens is facing upward. 6 haptic pads ensure a better stability. Angled haptic vault is selected to prevent excessive vaulting. It ensures the minimum friction between the iris and the anterior surface of the lens during iris adaptation to the light condition. The advantage of hole in optic haptic vault is that it allows equalizing the pressures between the posterior and anterior chamber. The 2 holes to the optical zone margin ensures continuous aqueous flow from posterior chamber to anterior chamber. These holes will be placed superiorly to avoid any glare or scattering to the light due to halos. IPCL loading. Now coming to this, this comes with the experience hand. The technique, the main tricky part is the measurement and the loading of the IPCL. When we have the cartridge in hand, it should be it's a pre-filled with the saline, with the saline. Then put a minimum amount of visco in it, and it's just like loading an intraocular lens. Just one main thing remember is just to see the vault, the surface should be upward. And when you close it, check it in microscope, that is totally fitted well. A delivery system. IPCL is very easily to load and insert. IPCL is thin, yet robust IOL and can be handled easily. Manipulation during loading of IPCL in cartridge as well as tuckling behind the iris is easy. Lens can be loaded in very short time, and overall procedure time is less compared to other posterior chamber phakic lens loading and implantations. We do not need any special instrument for surgery except an IPCL manipulator for tuckling lens behind the iris. The third is surgical steps, surgical procedure. There's topical anesthesia is preferable. There are 2 paracentesis points. What I do is, I don't do paracentesis first. What I do is, I first load the lens, keep it ready, then proceed with the procedure, make the incision, put some intracameral Jalocard just to anesthetize the iris, make the main port, implant the lens, manipulate it, and totally thorough visco wash. That's more important in doing a phakic IOL. IPCL injection is just like injecting a normal foldable lens. Manipulating the haptics, put viscoelastic on the top of the lens, give yourself more room, manipulate the periphery via paracentesis, distal haptic first and the pupil maximum dilated, avoid going across the central lens, manipulate the body of the IPCL, avoid on the optics. That's more important point. Part 2, the injections of IPCL above iris plane, injection of viscoelastic on top of this. If the IA, do a thorough IA to complete the viscoelastic. Need of surgical post-operative observations, basically it should be checked after 2 hours, and then just check the IOP is normal, check the vault of the IPCL after post-op. That's the more important points. 3 months OCT evaluations should be ideal. Step 5 is my experience. It gives a very good result. The patient can read nearly 6/9 second post-op day. Post-op data, 3-month post-op patient. This one patient I have just mentioned. IPCL for liscal, IPCL hyperopia, smart torics. These are the different IPCL models available. So these are the 5 easiest steps to ensure predictability outcome. What I'll suggest to take home message is be fast, be precise, don't panic if something goes wrong, just to handle the eye and respect the tissue. Thank you.